Welcome back. In the chapter of healthcare of the community, we are going to discuss about the primary healthcare. In the previous video, we discussed about the levels of the healthcare. This is the second part of the healthcare of the community where we are going to discuss about the elements and the principles. Let us begin with the term primary healthcare, which came into existence in 1978. You can see that the term primary healthcare came into existence in 1978. It came into existence in 1978 in the international conference at Alma Ata. The international conference which was held at Alma Ata in 1978, then the primary healthcare came into existence. The term came into existence in 1978 in the international conference held at Alma Ata. You can see the international conference which was held at Alma Ata, and the primary healthcare term was coined. Now we have the definition of primary healthcare. Primary healthcare is the essential healthcare. So when we discussed the levels, we saw that primary is essential, basic is essential. Primary healthcare is the essential healthcare which is made universally accessible to the individuals, and it is acceptable to them through their full participation. So we see that the primary healthcare or the essential healthcare, it is made accessible to all the individuals and it is acceptable to them through their full participation. So the community, the individuals, the primary healthcare is made acceptable to them with their active and full participation. And the primary care should be such that it should be affordable both by the community as well as the country. It should be at a cost the community and country can afford. So in the definition, there are three things you have to remember. The primary healthcare, it should be made accessible to the individuals. Next, it should be acceptable. It should be acceptable to them. And it should how is it acceptable? By showing the full participation from the community. Full participation from the community is observed. Then it should be at a cost which is affordable. 3A you can remember like this. It should be accessible, it should be made accessible to the people, and it should be accepted by them by their active full participation, and lastly it should be affordable for them. Okay, and also it should be affordable to the country. Now let us understand it with an example of corona vaccine during COVID. Okay, corona vaccine was introduced. It was such that it was made accessible to all the individuals. It was acceptable to them through their full participation. We saw that the entire community got vaccinated, and it should be at a cost that the community can afford. And also, for instance, let us consider each individual, it is costing 50k bucks for the government to provide vaccine. If per head 50k, is it possible for the country's government to afford such costly vaccine for all the people of the community? Absolutely not. It is not practically possible. So we see that it should be the service should be such that the healthcare should be such that it should be affordable by the community as well as the country. It should be made easily accessible to the individuals, and they have to accept it by their full participation. This was all about the definition. Very clear with it. Next, moving on to the elements of primary healthcare. Guys, we have 4 principles and 8 elements. See, 4 principles and 8 elements. Now, how do we remember this? 4 principles. Okay, 4 principles. The ulta of this, the reverse. Okay, P 4. 4 principles. Elements, close it off, close the E. Elements are 8. Round it up, it becomes 8. So we have 8 elements and 4 principles. Starting with the elements of the primary healthcare. So in your vivas, if the examiner asks you, list out the elements of primary healthcare, how are you going to begin with? Though the services which are provided by the different countries will vary, the Alma Ata has outlined this 8 essential components of primary healthcare. When they ask the elements, you have to say 8 essential elements. Now let us list out the essential elements which are provided by the primary healthcare. The first one is the maternal and child healthcare. Very important, MCH. The first thing is the maternal and child health care, including the family planning services. We also give the family planning service. So we have the maternal and child health care. Second, education. Third, food. Fourth, water. So education, food and water. Basic essentials, guys. What are the essentials? Food, water, education. So this is how you can remember. Now let us see. Food. Proper nutrition and food supply. Proper nutrition and food supply. Promotion of safe water and basic sanitation. So we are promoting the safe water, adequate supply of safe water and the basic sanitation by the introduction of latrines and everything in the villages. Then we have this promotion of safe water and basic sanitation facilities. So these are the two things. Next we have education. Education, which is concerning the health problems, and the educating the people how to control it. So we are educating the people regarding the health problem and also how to control the health problems. Okay. So regarding this cholera and all, okay, because how is it transmitted? So we have to ask them to maintain the hygiene, but the contamination has to be avoided by educating the people regarding the health problem and also how they can control this health problem. The education is given. So let us summarize these 4 points, then go to the other 4. First 4, guys, by now you're very clear. MCH, maternal and child health care, is provided along with the maternal, right? So also the family planning is given to the mother right after the delivery, or also if she wants to conceive, and how to space the children post delivery, what are the family planning methods she can opt to, which we have discussed in detail in our topic demography and family planning. Next essential element is food, water. Then we have education. Food, what will you write? Proper nutrition and food supply. Water, you'll write the promotion of adequate safe water and basic sanitation. Lastly, education. Education regarding the health problems and how to control them. So we are done with the first 4 points. Moving on to the next 4. The immunization against the infectious diseases or the vaccine preventable diseases. So we are having this immunization schedule, which is carried out by this primary PHCs, CHCs. PHC will keep a record. Okay, these primary health centers, sub centers will keep a record of this immunization. So the immunization against the infectious diseases and also the vaccine preventable diseases. Control of locally endemic diseases. So we are providing an immunization against infectious diseases, control of locally endemic diseases, then giving the treatment for the common diseases, and provision of essential drugs. How do we give the treatment? By providing drugs, provision of essential drugs. So what are we doing, guys? Immunization is given again for the infectious diseases. For endemic diseases, we are educating the people regarding the control of the locally endemic diseases, prevention as well as the control of locally endemic diseases. And we have the common diseases. We are giving the appropriate treatment for the common diseases and injuries and provision of essential drugs. So very clear. Next 4 points: immunization against the infectious diseases. Then we have endemic diseases, where we are teaching about the prevention and control. Next we have common diseases, where we are giving the treatment. And lastly, the essential drugs are given to treat this. So we are done with the 8 elements. So I want you to list it out. So what did we see? MCH, food, water, education. This completes the 4 points. Next 4, immunization for the infectious diseases. Then we gave the control and prevention for the endemic diseases, followed by the treatment and provision of drugs. So we are very well versed with this 8 elements. So whenever an examiner asks, even in your theory, viva, or any MCQ question appears from this, we have many MCQs. The underlined parts in all our videos are MCQs. So any question arises, we are ready. Now we move on to the principles of primary health care. So the 4 principles or the pillars of primary health care include the equitable distribution, community participation, intersectoral coordination, and appropriate technology. So it is, now you just can't memorize all of them. So when we deal with each point, and then we'll come back to the slide, and let's see if we are able to tell all the 4 principles memorized. The first one, equitable distribution, communities participation, intersectoral coordination, and appropriate technology. Beginning with equitable distribution. So we see that the first key principle in the primary healthcare strategy is equitable distribution of health services. What do they mean by equitable distribution? The health services must be shared equally by all the people. The health services, so you can see equitable, it means what? The health services should be shared by all the people, irrespective of their ability to pay. All the people, in the sense, the rich, the poor, people residing in urban areas, people residing in rural areas, all the people should have the access to health services. Example, shifting the center of healthcare system from the cities to the rural areas. So guys, you can see here equitable distribution, where the health services are made accessible to all the people, irrespective of their ability to pay. Now you're shifting the centers of healthcare system from the cities to the rural areas. You can see here, this is a PHC, this is a CHC, and equitable. There is a clear difference between equal and equitable. Okay, equitable is so you can see, in equality, this guy gets a box, this other guy one box. So he is not able to watch the cricket or whatever the game is going on. Here, when you do the equitable distribution, the one who needs it will be provided adequately, and based on their needs, the services will be provided. The one who is requiring more care will be given more attention, followed by the other people. So this is equitable distribution. Now for example, if there is 2 people, okay, one is rich and the other one is poor, you are giving 100 rupees, where you're giving 50 rupees to both of them. So you're doing the equal distribution in both of them. If you're giving the same 100 to the poor who is in need, you're giving 80 rupees to him and 20 rupees to the poor, to the rich. It shows that you're doing an equitable distribution, where the more amount is given to the poor. Similarly, the health services will be given to the one who is in need. Okay. So this is about the equitable. They didn't say equal distribution. They said equitable distribution. So you have to, stress on this point. Moving on, the equitable distribution, to make you understand this, you can see that These urban areas, they contain all the specialized, hospitals, central hospitals, regional hospitals, institutions, colleges, and all the specialized hospitals like Nimhans, and we have Apollo hospitals. All such hospitals, specialized centers, and emergency cares, everything is centered in the urban areas. So what the government did was, now these if you ask this Apollo hospitals to go open in some village, will they do it? No, they won't agree to such things. So what the government did was, in order to distribute the health, to the rural areas, they came up with this CHC, PHC, SC, and Anganwadi. So now, what is the CHC? CHC is a community health center. PHC is the primary healthcare center. This is the sub center and Anganwadi centers. So we see that the centered is the urban areas where it contains all the multi-speciality hospitals, emergency care units. So what they did was, they divided the urban areas in blocks. So this was one block which had one CHC. This was the other block which had another CHC, the other block which had another CHC, and this was the fourth block which has another CHC. And now, further division, one CHC was subdivided into four PHCs. One CHC, okay, one block, in one block, now let us consider, in one block there was one CHC, and under that we had 4 PHC. PHCs were 4. Again they subdivided one PHC into 6 sub-centers. One PHC had 6 sub-centers. And now all the villages, okay, all the villages all together, so this is a village, this village all together will form one block. And for each village they had an Anganwadi center. Okay, each village had an Anganwadi center. So we had a picture here. We see that one block, this is another block, third block, fourth block. So we have one CHC, 4 PHCs, sub-centers are 6. Each PHC, under each PHC we have 6 sub-centers. You can see 1, 2, 3, 4, 5, 6. So 1, 2, 3, 4, 5, 6. 6 sub-centers will be there under each PHC. And so all the villages together will form a one block, and each village had an Anganwadi center. And urban areas, we had district hospitals, CHCs. Urban, we also have this urban PHCs. You might have had your postings there as community postings, where you went visited the PHCs, CHCs. So we also have the urban PHCs and CHCs, but they are comparatively less compared to this district hospitals and specialized hospitals. So we see that for beginning with the CHC, one block population contains 80,000 individuals. If it is a tribal and hilly area, 80,000. Okay, population is that of 80,000. If it is plains, it is 1,20,000. One block contains 80k or 1,20,000. Moving on, one CHC is for 80,000 population. Next, PHCs. 4 primary health centers are found under one CHC. So we know one block contains one CHC, under which we have 4 primary health centers. And the population, which is the one PHC covers about 20,000 population to 30,000 population. 20,000 if it is hilly area, 30,000 if it is a plain area. So 20k to 30k. One PHC contains 1 PHC per 20k population. Next we have sub-center. So the sub-centers, for per 3000 population we have one sub-center. Okay. So 3000 to 5000. Hilly areas or tribal areas 3000. If it is plain, 5000. Next, one Anganwadi center for each village. So clear, guys? In CHC, what did we see about the population? 80k to 1,20,000 population, we have one CHC. Regarding the PHCs, we saw that one PHC is for 20 to 30k. If it is hilly area, 20k. If it is plain, 30. Next, one sub center for 3k to 5k. 3k to 5k. Lastly, one village will have one Anganwadi center. Clear, guys? 80k to 1 lakh 20k, 20,000 to 30,000, 3,000 to 5,000. So we are done with the population under each PHC or CHC and Anganwadi center. In urban areas, they centered this hospital. So in order to provide the healthcare, to provide the healthcare even to the rural areas, they directed this Anganwadi center, CHCs, PHC. The more focus was given in the rural areas because it is it is accessible, it is made accessible to the individuals, it is easily acceptable, and also it is affordable. It is affordable by the people. This is how the primary health care was provided. Moving on to the community participation. So we are done with this primary health care. Next, we have the community participation. So the involvement of the individuals, the involvement of the families and the communities in the promotion of their own health and welfare, it is a very essential ingredient in the primary health care. So we see that the involvement of the community in planning, implementation, maintenance of health services, besides the maximum reliance on the local resources like manpower, money, and materials, this continuous effect, okay, the continuous effort by this community in the planning, implementation, and maintenance of health services has brought a lot of improvement in the health of the people. So in the community participation, we are focusing in the involvement of the community. We want the community people to get involved in the planning, in the implementation, and the maintenance of the health services. So the community participation, you can see the one approach is that of the use of village health guides. So one approach is such that they tried, which has been comparatively successful in India, is the use of village health guides and the trained dais. Okay, trained dais. These village health guides will be selected by the local community and they will be trained locally. These health guides, they are selected by the community people. You can see this trained dai or this Anganwadi worker, Asha worker. They are chosen by those people in the community themselves. So they are first elected by the local community, and then they will be trained locally in the delivery of these primary health care to the community. They are they will overcome such cultural barriers, communication barriers. So the physician, now if you ask a urban physician to go to a village and explain the village people or the rural residing people the health services or regarding a health problem or a disease, the understanding and the level of the communication will be comparatively very difficult, and it will be not that understanding to the villagers or the people, local people there. In fact, if you use this village health guides, if you choose a person, train them locally, and then you can overcome the cultural barriers, you can overcome this language barriers, and all such barriers can be broken down, the communication barriers, cultural barriers, and this primary health care can be made more acceptable to the community. Okay. So now we know that the Asha workers, Anganwadi workers, they are also playing a very essential feature in this primary healthcare in India. So the community participation, you're going to write about the Asha workers, Anganwadi workers, barefoot doctors. We also have this barefoot doctors in China. So the Indian people have greatly influenced by their experience in China, where they saw the participation of this barefoot doctors and TBA. So we are done with the Asha, TBA, barefoot doctors, Anganwadi workers, village health guides, where the active community participation is seen in planning, implementation, and the maintenance of the health services. So, in short, we see that the primary healthcare must be built on the principle of community's participation. Moving on to the intersectorial coordination. So, inter is what in between two things. So, we see that intersectorial, though it is this is one sector and this is the other sector. Let us consider this as the health sector, this is agriculture. Intersectorial, okay, intersectorial coordination. There is an increasing realization of the fact that the components of the primary healthcare cannot just be provided by the health sector alone. So they have come to a realization that the health sector alone cannot deal with the complete primary healthcare. So the declaration at the Alma Ata stated that the primary healthcare should also involve the addition of the other sectors into the healthcare. What are the other sectors? In particular, we have agricultural sector, animal husbandry, food industries sector, education, housing, public work, communication, and other sectors. So why are we using these sectors? To achieve the cooperation, these sectors are involved in planning the health services so that they can avoid the duplication of the activities. So we see that important element is we are avoiding the duplication of the activities. For example, now if the agriculture sector is it is educating you regarding the certain health problems, and it is teaching you certain thing, so that can be avoided by the health sector can avoid it. If animal husbandry, if they are trying certain vaccines on the animals and then they are proving it on the animals, and they have already list out, and then they have tried it and they have already list out the things, then the health sector can should avoid the duplication of activities. They have to stop doing this and focus on the other things, so that we can avoid the duplication of the services. The intersectorial coordination should be done between the animal husbandry, agriculture, industries, education, housing, and health sector. Okay, clear guys? This is all about the intersectorial coordination. Also, we have an example of Rogi Kalyan Samiti. Rogi Kalyan Samiti, where the school principal, the health worker, and those heads will join together, and they will have an intersectorial coordination wherein the duplication of the services. The main goal of Rogi Kalyan Samiti is to avoid the duplication of the activities. These workers will work together and they will avoid the duplication of the services. This was all about the intersectorial coordination. Clear, guys? Okay. Now, we are moving on to the appropriate technology. Appropriate technology is defined as the technology which is scientifically sound. Appropriate is correct. It should be sound technology. Scientifically, it should be sound. It should be adaptable to the local need. Like we saw all the health services, including the technology, it should be such that it should be adaptable to the local need, and it should be acceptable to those whom it is used. It should be maintained with the resources community can afford. So similar things, what did we see? It should be accessible or adaptable. Then it should be acceptable. It should be affordable. The technology should be such that it should be scientifically sound. It should be adaptable to the local need. It should be acceptable by those who are using it, and it should be maintained with the resources community such that the community can afford. So we can see the vaccines and everything. So an example we have is that of an ORS. So the technology, you can see that under appropriate technology, we are having an example of ORS, oral rehydration therapy, where It is socially acceptable and financially more feasible instead of IV fluids. So in IV fluids, if you ask the patient to take an IV fluid, charging rupees 500, and instead of and he has to travel a lot from the rural area. He has to go to that CHC or the district hospital, which is so many kilometers away, 30 or 40 kilometers away, and then he has to get this IV fluid. So if you ask the patient to take an ORS, it is more affordable, it is more acceptable, easily adaptable. He has to just mix it in water and drink it. So this is more acceptable, affordable, and adaptable by the community rather than that of the IV fluid. And we also have the example of this growth charts. So we see that the growth chart, which is used for monitoring the growth of the child. So we have this growth chart, road to health chart. We have discussed about this in our demography and family planning chapter. You can see in the playlist the entire topic and the entire chapter has been discussed there, where we studied about the growth chart. Okay, and then we have the VVM is the vaccine vial monitor, where we have this vial monitor, vaccine vial monitor. We have this small indicator which is heat sensitive. So if the vaccine is exposed to a temperature more than 2 to 8 degrees Celsius, the color of this this strip changes and it becomes darker. So these two are not, they should not be used. It indicates whether the vaccine is in the condition where it can be used or not. This should not be used. So if in the first stage 1 and stage 2, you can still use. So we'll make separate video of this when we are doing the immunization chapter. When we do the epidemiology chapter, we will discuss about the vaccine vial monitor. And then we have biogas system as well. Next, the standpipe in rural areas and Shakir step. Very important, guys. Shakir step, where the malnourished children, the mid-arm circumference of the child, the mid-arm circumference of the child will be measured, and very clearly, simplest way you can see, if it is falling under the red, the baby is malnourished. If it is yellow, it is heading towards being malnourished. And if the baby is having a chart, a reading which is falling under the area green, it shows that the baby is healthy. So we know that the Shakir step for the malnourished baby, and we also have the standpipe in the rural areas. So this was about the appropriate technology. We saw that the technology should be adaptable, acceptable, maintained such that the community can afford. We have an example of ORS, vaccine vial monitor, and we have vial monitor and growth charts and Shakir step and the standpipes, biogas system, etc. So this was all about the appropriate technology. What are the broad principles of this primary health care? Before going to the broad principles, let us revise what we have studied. So what are the 4 principles we saw, guys? The first one was the equitable distribution. In equitable distribution, what did we see? The health should be provided to all the people, equitable, irrespective of their ability to pay, whether they are rich, poor, whether they are residing in urban, local. We have to do a equitable distribution, under which you can explain the distribution of this in urban areas. All the district hospitals, the regional and central hospitals, specialized hospitals are located. So the government made an approach to for the equitable distribution of the health services to the rural areas, wherein the CHCs, PHCs, sub-centers and Anganwadi centers for each village was designed. And then we have communities participation. In communities participation, what did we study, guys? Communities participation, where there was involvement of the community in planning, implementation, as well as maintenance. Planning, implementing. First they will make a plan, then they will implement the plan. Planning, implementing, that is bringing into action, and maintaining the health service. Okay, planning, maintaining, as well as implementing, and then maintaining the health services. So who were the ones who were involved in community participation? We had this village health guides, trained dais, ASHA workers, Anganwadi workers, barefoot doctors, all of those. Then intersectorial coordination. In intersectorial coordination, we know there is a coordination between the healthcare sector along with the agriculture, animal husbandry, food industry, education, housing, etc. So the primary healthcare alone is not able to deal with the health sector. So in order to prevent the duplication of the services, we had this intersectorial coordination. Okay. Next, we have appropriate technology, under which we studied about the ORS, growth chart, Shakir's tape, and all that, where the technology should be such that it should be scientifically sound, it should be adaptable to the local needs of the people who are applying it, and it should be, maintained by the people themselves. Okay, it should be self-reliant and it should be affordable by the people. It should be financially feasible or affordable. So this is all about the principles of the primary healthcare. Can you list it out? What are those? What are the 4 principles? What did we see, guys? First one, equitable distribution. Second, communities participation. Third, intersectorial coordination. And the fourth one, last, was appropriate technology. Clear, guys? We are perfect with the principles and elements. Now we are moving on to the broad principles of primary healthcare. So the primary healthcare, they have this broad principles. Okay, equitable distribution, intersectorial coordination. These two we had already seen. The other two is the national coverage, the entire national coverage. They have the national coverage and self-reliance. We saw that it should be self-reliance. So example, ORS, self-reliance. Okay. Next, qualitative enquiry. If a question arises, qualitative enquiry, this is a new concept in primary healthcare. So guys, this is an MCQ question we found in a previous paper. The new concept in primary healthcare, the MCQ for what? NEET pre-PG examination. Okay, PG entrance exam, all the previous year question paper, the relatable questions have been marked as the underlined questions, underlined points, and all the videos are the MCQ questions which have appeared in the previous examinations. So we see that the new concept in primary healthcare is the qualitative inquiry. Avoids advanced decisions about what is to be discovered. We are not taking this advanced decisions about what is yet to be discovered. And ask open questions. They are asking open questions to explore the new interpretations. So we are avoiding all such discussions wherein the things what are not yet to be which are not yet implemented, we are avoiding those things, and we are focusing on providing this essential primary healthcare. Okay, avoidance of advanced decisions about what exactly is to be discovered, what we have to discover. Avoid such advanced decisions and ask open questions so that you can explore the new interpretations from the people. So this was about the principles and the qualitative inquiry. Moving on to the last slide of a video, that is comprehensive healthcare. Comprehensive healthcare was first used by the Bohr Committee in 1946, another MCQ. So we see that the comprehensive healthcare was used by Bohr Committee in 1946. The Bohr Committee used the comprehensive healthcare, where there was a provision of integrated preventive, curative, promotion. Okay, promotional health services from the womb to the tomb. Okay, from the womb to the tomb, to every individual residing in a defined geographic area. So we see that we are giving the promotive, curative, preventive, cure, treatment, or the health services from the womb to the, you can see, from the womb of the mother to the tomb after the death. Okay, so from the womb to the tomb to the every individual. Under the comprehensive healthcare, the integrated, preventive, curative, promote the health, prevent the disease, and cure. In case a disease arises, cure. These are the 3 things we always see. So promotional, preventive, curative health services from the womb to the tomb. Moving on, what is the criteria for this comprehensive healthcare? It should provide the preventive, curative, and promotive health services. In the first place, provide preventive, curative, promotive health services. It should be very close to the beneficiaries as possible. So, imagine this is the specialized hospital, and this is a village, and here the person has fallen sick. So, it should not be such far, it should be very close to the beneficiaries, like a sub center very close, and one anganwadi center for each village, and then we have chc. So it should be such that it should be very close to the beneficiaries as much as possible. It should be close, it should be available to all irrespective of their ability to pay. Very important. The comprehensive healthcare, just like the primary healthcare, it should be such that it should be made available to all, because health is a right of an individual, it is the basic right of an individual. So it should be such that it should be made available to all the people irrespective of their ability to pay. Look after the vulnerable and weaker sections of the community. So we have to look at the weaker sections of the community, the poor people, the urban area, the rural areas where the health services are not being available to them. So we don't have an emergency care, we don't have ambulances available in such rural areas, background and slums, all such cases, all such areas, the weaker sections of the community, they have to be looked after. Create and maintain a healthy environment both at home as well as the working place. We have to maintain a healthy environment. The sanitation, the hygiene has to be followed. We have to promote and prevent the health of the community should be maintained. So this was about the criteria for the comprehensive healthcare. Let us summarize. What is that? We have to provide a preventive, curative, and promotive health services. The services should be close to the beneficiaries. It should be available to all irrespective of their ability to pay. So it should be close to all. Then it should be made available to all irrespective of their ability to pay. It should be looked after the vulnerable and weaker sections of the community, making available, also focusing on the weaker sections of community, and maintaining a healthy environment in the workplace as well as at home. So, with this, we come to an end of the second part of the healthcare of the community, where we discussed about the principles, elements, and lastly, the comprehensive healthcare. Let us quickly brush through the MCQs which have appeared in the previous papers of our NEET entrance, PG entrance examinations. Starting with the term primary healthcare. Elements. So elements, the education which is concerning the health problems and their control, promotion of safe water and basic sanitation, immunization against infectious diseases, control of locally endemic diseases, and provision of essential drugs. So these points I have found in the previous questions. Next we can have the other points, and they will ask you which are the points included and which are not included. So you can say we have memorized this MCH, food, water, education. So thereby you can rule out what is not there and what is there. Okay. Next we studied the immunization which is given to the infectious diseases, and endemic diseases are where there is a control, and common diseases are treated with the use of provision of essential drugs. Next, moving on to the principles. So principles are very important from your theory point of view, or Viva. MCQs can also appear where there is equitable distribution, communities participation, intersectorial coordination, and appropriate technology. So under equitable distribution, we have an MCQ. How are we providing this equitable distribution? By shifting the centers of healthcare system from the cities, from the urban areas to the rural areas. Okay, we are shifting the healthcare services to the rural areas. Yeah. Next, we have the appropriate technology, wherein the standpipe in rural areas and Shakir's tape. ORS. These are the examples of the appropriate technology. And the broad principles of primary healthcare, very important: social equity, national coverage, self-reliance. It should be self-reliance. Yeah. Next, we have the new concept in primary healthcare is the qualitative inquiry. And the comprehensive healthcare was first used by the Bohr Committee in 1946. Bohr Committee Comprehensive Healthcare. So these were the MCQs, and I hope everything is clear. If you like the video, hit the like button and subscribe.